amputation after transplant in single ventricle from 1 to 4 valves, to be given by Dr. Louise Coates, adult congenital cardiologist from Newcastle University in the UK. Dr. Coates.
Thank you very much, and thank you for the kind invitation to speak here on behalf of the Newcastle team, and also for the slightly cryptic title for my talk, which took some thinking about, I think, to get to. I think this has already been shown to some extent, but our experience in Newcastle, where we are the main centre in the UK for transplanting adults with congenital heart disease, is that our referrals for those with single ventricle and specifically Fontan circulations has been increasing really quite rapidly over recent years. And these patients, when we compare them to those with biventricular adult congenital heart disease, are on average around 8 years younger, and much more of a male-female balance. We've talked already, and these pictures are well known to you, about the nature of failure in the Fontan circulation, and the pulmonary vascular resistance being the bottleneck, if you like, for an effective circulation. But by the time the patient comes to transplantation, there's also several other concerns in terms of their risk and their outcomes for transplantation. These, of course, involve the technical aspects, the fact that most have had multiple stenotomies, the complex anatomy, the venous access, importantly, the bleeding risk, and the collaterals are a key concern here. And the unknown contribution, perhaps, of the liver disease to that bleeding risk. Many patients are sensitized, and I guess more recently, we've really begun to recognize the importance of the body constitution in these patients. Many of them are very deconditioned, low-end normal of BMI, low grip strength, and the psychological aspects that living with the Fontan circulation have impacted them on over their life, and they embark then on what is often a long and complicated course through transplant. But we know from overall ISHLT data that when we transplant adults with congenital heart disease, although there are difficulties in the early period following transplantation, over the much longer term, outcomes are better than those with non-congenital heart disease in terms of survival. But it's the early period after transplantation that is described by some as the Achilles heel for adults with congenital heart disease, where the mortality is seen. As centres have had increasing experience with Fontan transplant, we've been able to get comparable outcomes for the single ventricle patients to those with biventricular circulations. But this is perhaps not reflected in the degree of support and the degree of morbidity that these patients experience. And this very useful review that the Toronto team published recently, which I'd recommend really for anyone who would like to understand the situation for Fontan transplant as it stands at present, identifies really what are the risk factors both for the patients on the list and the patients post-transplant. In terms of, I sort of highlight the patient-related factors here because it's the failure of the Fontan, the low cardiac index, the high PVR, the high Fontan pressures, that actually are the risk factors for the patients dying whilst waiting. And this reflects the advanced nature of the patients that we're listing for transplant. Post-transplant, the comorbidities start to impact with the renal dysfunction, the liver dysfunction, and as us and others have seen, those with the preserved ventricular function are at highest risk. And this is from our own data. As mentioned, that group of adult failing Fontans with preserved ventricular function and really the circulatory failure proved to be those who often experience the early complications after transplant. But when we look more at our recent data, we see that more than the preserved ventricular function, it's actually the surgical bleeding that really determines that early outcome. And the surgical bleeding, as we've already discussed can relate to several aspects of the Fontan circulation, but most specifically the difficulty with collaterals in these patients. And it's our practice, and I think others, to embolize aortopulmonary collaterals in the lead up to transplant to try and reduce this risk. And at the time of transplant, we may use supranormal cardiopulmonary bypass flows to account for flow and to maintain perfusion through the operation. This is quite an old paper, and I think the only one that really looks at this, as to what happens to the pulmonary vascular resistance in the transplanted Fontan patient. The paper itself looked at catheters before and after 15 patients with Fontan. Of those, 11 were late failure Fontans, and most the age of these patients they were adolescents and young adults who underwent heart transplantation. And we can see, and this is the paired data from the study, but we can see already that how difficult measuring the pulmonary vascular resistance is in these patients because preoperatively, because they were only able to provide three paired data. But we see in those 3 patients that the PVR following transplant, along with the increase in transpulmonary gradient as the cardiac output increases, increased, and it increased to 3.5 Woods units, which we would consider to be a pulmonary hypertension. In the 10 patients who had post-transplant catheterization but did not have pre-transplant PVRs measured, the mean Woods units was 3.8, so it was seen across the wider group. And so one of the concerns in the Fontan post-transplant, in the early period post-transplant, is that we unmask this unseen pulmonary hypertension, which is difficult to assess and measure beforehand. When we look again in our own group, because we might think that this may lead to graft dysfunction, we do see graft dysfunction occurring, and occurring at quite a high rate. In our recently published series of 31 cases of Fontan transplant, we had 8 cases of graft dysfunction, 4 right ventricular dysfunction and 4 left ventricular dysfunction. So perhaps not completely due to the PVR. This is at the upper range of what's reported in adult congenital heart transplant. But what we see from our mortality curves as well is that we're really, post-transplant, quite able to support these patients, and that graft dysfunction on its own, unlike bleeding, does not affect the mortality in the same way. But whilst mortality is not increased in these patients, morbidity is, and especially in the context of the need to use ECMO. Another important thing, and I think this relates back to the assessment of the liver in the Fontan patient, is the occurrence of vasoplegia. We know that after heart transplant, vasoplegia can occur, and in general is reported to be in the range of around 10%. Vasoplegia being persistent low SVR despite the multiple high doses of vasopressors given. And the Fontan patient themselves may be at specific risk for this. There is some evidence recently that suggests that a symptomatic adult Fontan patient has, compared to the asymptomatic pediatric Fontan patient, a reduced SVR with a relative preservation of the cardiac index. And perhaps this is related in some way to liver disease. I think this was discussed very nicely yesterday by Christian Besler in the setting of tricuspid regurgitation about the effect of the liver on the cardiac hemodynamics. Of course, we know there's evidence for reduced endothelial function, and some patients may also be on aspirin. There are other more general risk factors, but these patients obviously have longer cardiopulmonary bypass times. And vasoplegia can be very difficult to manage and associated with these complications. And then, of course, the transplanted heart itself has a very different physiology of its own. It's a denervated heart. It has a chronotropic incompetence, which, of course, the Fontan patient will be used to. And it's dependent on circulating catecholamines for its stress response. So how do we support the patient who has the Fontan and is then transplanted? Well, actually, the prehabilitation of the patient is incredibly important, because we are in the UK at least currently in the situation where our listing of patients very much is in the advanced status of their Fontan circulatory failure. Keeping them in on milrinone with a degree of diuretic, paracentesis if needed, nutrition and active physiotherapy can help improve them prior to transplantation. And in fact, we can see MELD scores fall, in particularly with those who have ascites and have recurrently paracentesis. At the transplant, oversizing of the donor graft to deal with the pulmonary vascular resistance. The organ care system, the Transmedic, has allowed us to give the surgeon more confidence and time to complete the dissection whilst the organ is maintained. Pacing post-operatively in the transplanted heart is a standard practice. And then also post-operatively, the use of milrinone, nitric oxide, semi-elective ECMO in the cases where we're concerned about vasoplegia, or perhaps where surgical bleeding has been an issue, and in some early hemofiltration. So to bring the valves in this from one valve that reflects many of the problems we experience after heart transplantation, and that's the tricuspid valve, because the tricuspid valve reflects very much when difficulty is encountered on the right side of the heart, when the PVR is perhaps high, when there's graft dysfunction. But this, if we can use it as our method to assess and manage the ventricle and the new heart, then we can succeed and go forward to the valves then working. And once the 4 valves are restored and the circulation is restored, we have really quite encouraging results to show that we can reverse many of the complications of the Fontan circulation. And for those who present with PLE and plastic bronchitis, that reversal is relatively quick. With the liver disease, the stabilization and improvement takes longer and is reported to occur over many months, but with early signs seen that are beneficial. Of course, the liver still needs surveillance because the liver disease is still there and there is still the risk for things like hepatocellular carcinoma. But in a non-congenital case report, there is in fact a report at 10 years of full resolution of cardiac cirrhosis. So then when do we need to replace the liver in these patients? There is potentially some benefit of replacing the liver in terms of the immunological benefit liver transplantation confers. But the role, I would say, is unclear and very much led by our different listing criteria for these patients across different countries. This is our first heart liver transplant, and in terms of the valves, is quite an interesting patient because he was one of the first series reported by Magdi Yacoub, who had 3 valves in their modified AP Fontan, one in the SVC, in the IVC, and one in the outlet to the pulmonary arteries. And he presented at the age of 47, and this was the state of his liver at that stage with significant bridging fibrosis. It's our general practice in Newcastle to perform heart-alone transplant when there's normal synthetic function, preserved liver volume, normal venous anatomy, and absence of significant portal hypertension and no hepatocellular carcinoma. But we need to perhaps rethink about what our thresholds are for this when we have better evidence of how reversible liver disease is after the Fontan. When we look back at our cases, we don't see a case where the patient died because of acute liver failure. Rather, we see the cases where the patient died because of vasoplegia or because of significant bleeding stimulating a cycle of events. And these are the 4 cases that we have now transplanted from a heart-liver perspective. A clear indication, I suppose, being the hepatocellular carcinoma, which differs a little bit from the others. But is transplant a realistic proposition for the Fontan population? in 2017-18, there were 196 pediatric Fontan procedures performed in the UK and 197 adult heart transplants. So clearly, we do not have enough organs for these patients. I think the question we have to ask ourselves is how, instead, we gain equity for these patients in accessing the organs at the right time and at the point where they are the most suitable for that intervention. In the UK, very few patients get transplanted from the non-urgent list. Most wait, some get escalated, and some die. The vast majority of patients get transplanted from the urgent list. And in the UK, we have, around 10 years ago now, separated criteria for the adult congenital heart disease patient, which differs from the non-congenital patient. But perhaps within this, we need further division for the Fontan patient. I think I would agree with Jack that our better understanding of not only the morphological function, but the hemodynamic function of the Fontan before transplantation will be key to understanding when and in who transplant should be done. Because I think what we want to achieve for the Fontan patients is not that we can transplant everyone, but that we have equity to access for organs, and that requires a different consideration of what the physiology is. So just to finish with a picture of one of our patients, because I think this provides the best demonstration of actually how the physiology does change after heart transplant when it is successful. Vicky was a 32-year-old who had left atrial isomerism, unbalanced ABSD, Asger's continuity of the IVC, and was repaired with a Kawashima with keeping some forward flow from the ventricle to the pulmonary arteries as well. When she presented to us, she had severe ascites. You can see in the picture on the left, her exercise tolerance was really very limited, confined to a wheelchair most of the time. Angiography, which I haven't shown, is really quite interesting because the flow was forward from the heart and almost coming back down the Kawashima. She had significant abdominal collaterals that reflected the failure of the circulation. The picture on the left is with one of our surgeons, Mohammed Nassar, who himself engages as well in the prehabilitation of these patients. And following transplantation on the right, we see a different Vicky without the ascites, a significant improvement in exercise tolerance. So she underwent a very successful heart-alone transplant. So I'd like to conclude just by acknowledging, as I think many people outlined yesterday, that really the delivery of transplant to these patients is a multidisciplinary approach, and each patient is very different and has very different components, both of their physiology, their anatomy, and importantly also their psychology. And I think we have much more to learn to get it right and to continue to improve our results. Thank you.
That was a fantastic overview. I think we'll take 2 minutes for some questions or comments for anybody on the panel. Perhaps I can have you take a seat.